So we know from the SELECT data that patients who get lenvatinib in the first setting have a progression-free survival of 18 months. However, patients who get in the second have a progression-free survival of 15 months. So there is a slight advantage to giving lenvatinib in the first-line setting. That said, lenvatinib can be used very much in the second-line setting, so it's very helpful in that regard. But an interesting thing that also happens with lenvatinib, and can happen with other kinase inhibitors as well, but we use it especially with lenvatinib, is that many times patients at the time of progression may only have one site, one location that's actually progressing. And if that's the case, but say they have 100 other nodules that are responding well to lenvatinib, it could be deemed that the clinical benefit of lenvatinib still exists if we could just control the progressing site. And sometimes that's possible either using surgery, ablation, or external beam radiation to a particular site. And I've had many patients where the progression-free survival can be doubled or tripled just by managing solitary sites down the line that show progression. And so I think at this point, it's very useful to use lenvatinib in the first-line setting, but even in the second-line setting, it's very active. And most importantly, we can really expand the duration of the clinical value of lenvatinib by salvaging it with external beam radiation to solitary nodules that may not respond when the rest of the disease is doing quite well. So I think it's well known that there are not many community oncologists out there who actually trained in the treatment of thyroid cancer. Certainly it wasn't around when I was in training. And it's also quite rare for patients with thyroid cancer to need an oncologist. And for that reason, I guess the first advice I would have for a community oncologist is, if possible, refer the patient to a specialist who actually has experience both with thyroid cancer and with the use of these agents. Treating patients with thyroid cancer in these agents, even if you're used to using these agents in other settings, can be quite different, particularly in regards to the duration of treatment. Because the patients are on these drugs for so long, many times for years, it is very, very important that the practitioner understand how to mitigate the problems that come from the adverse events, how to mitigate the issues with high blood pressure control, how to mitigate the problems that come with diarrhea, that they know how to administer not only Imodium, but actually how to make sure that the patient's tracking it, and do the education required so that the patient can be successful. Because it doesn't really help anybody, including the practitioner or the patient, if the patient is miserable for the entire time that they are on these therapies. So the goal for the patient really needs to be not only control of their disease, but a good quality of life. So for those people who are giving it in the community, maybe haven't used lenvatinib very long, but they're in a place where referral is not possible, or the patient can't travel to a site of expertise, the most important tip I can give to the community oncologist is stay in close contact with your patient. Make sure that they know their blood pressure and are taking it reliably for several days before they start, and that they take it every day, twice a day, maybe even in the first week, so that high blood pressure can be addressed quickly and effectively. And so if you have a good partnership with your patients, I think you can expect to have a good outcome with these agents, and especially with lenvatinib in this setting. As far as unmet needs in the future, in spite of the good success and sometimes the 1 year to several years responses of patients with lenvatinib, eventually patients will actually progress. In the case of sorafenib, there was some data that adding in everolimus might actually help. And so I think we still have an unmet need of knowing what do we do after sorafenib and after lenvatinib. Current ongoing phase 3 trial is addressing whether or not cabozantinib, another kinase inhibitor that's approved for medullary thyroid cancer, might be active, and that's a phase 3 that's currently ongoing. Additional studies looking at whether or not adding immunotherapy might be helpful. Again, the data and the verdict for that is out, but we're looking forward to hearing that coming up hopefully in the coming year.